Sudanese Doctor Association in Qatar with the Sudan Diabetes and Endocrine Society. So my name is محمد Bashir. I am a consultant endocrinologist in Hamad Medical Corporation, and I will be the co-chair today of the session. First of all, I would like to introduce the chair of the session, Professor د.سلاف Ibrahim Abdulaziz. Professor د.سلاف is a graduate of University of Khartoum. She received training in diabetes and endocrinology, and she's currently a senior endocrine consultant. And she's also an associate professor of medicine, University of Khartoum. She's the former head of Department of Medicine in Soba University, and she has a member of multiple societies of relevance to this talk. Professor د.سلاف Abdulaziz is member of the IDF DAR International Alliance, and she's one of the authors of the most recent guidelines published last year. So without further ado, I will introduce our first speaker, and we're going to have a 23 talks, 20-minute session each, and after that we'll have a panel discussion. Please, if you have any questions, post them in the chat box, and we will gonna get to the questions at the end of the session. So our first speaker is Dr. Bashir. Dr. Musa is a consultant in family medicine in Primary Healthcare Corporation in Qatar. Sorry, can you make sure everybody is mute, please? Dr. Musa Bashir is a consultant in family medicine at Primary Healthcare in Qatar. He received a clinical MD of family medicine from Sudan. He has a master's degrees in clinical research from Dresden in Germany, and a master's degree in diabetes from Warwick University in United Kingdom, and received a postgraduate diploma in diabetes as well from St. George University in London. And Dr. Bashir is going to talk us today about the risk assessment of patients with diabetes who are willing to fast during Ramadan. Dr. Bashir, the stage is yours. Sorry, can we unmute Dr. Bashir? You're muted, please. Unmute yourself.
Okay. Thank you very much, my senior Dr. Muhammad Bashir, for your nice talk. Assalamu alaikum wa rahmatullahi wa barakatuh. I hope everyone is keeping well and staying safe. Ramadan Kareem and Mubarak in advance. I'm very delighted to be a part in this activity. Thank you very much for Sudanese Doctor Association in Qatar, and great thanks for Sudanese Endocrine Society. So, as we know, our problem, diabetes and Ramadan. The majority of Muslims with diabetes decided to fast Ramadan. We should respect their decision, but we need to initiate a comprehensive medical review and care, negotiate, discuss, and give them the best option to decide. So our objective today would be a holistic patient-centered approach. The risk.
Sorry, Dr. Bashir, I don't want to interrupt, but can you put this in a presentation mode, please? Put your slide on presentation mode. Slideshow. Go ahead. If you go down to the bottom.
Yeah.
Beside notes, keep going right. Keep going to the right. Okay, do you see slideshow at the top? Slideshow.
Yeah.
Slideshow. Yeah, just press on it. On your screen. Can you see the first line which say file, starts with file, home, insert, draw?
No.
Yeah, Musa, can you see on the light? You said, yeah, view, beside it review, and beside it slideshow.
Sorry, I can't see it.
Okay, it's in the top of your screen. Yeah, you're just animation beside it on your right of it, slideshow, right of it. slideshow. Yeah.
Move your cursor to the right. You will just hit it.
Let me share it again from the start.
No, it's okay. You don't have to share it again. Just can you see down at the bottom right? Can you see 86%?
No, I can't see it.
Bottom right of your screen. Bottom right of your screen.
I can't see it.
Bottom right. Can you see the line at the bottom right? It's okay. If you can't see it, you can go ahead. Just for the sake of time.
Let him to change the slides just by pressing the cursor, Musa. Musa, bet the cursor in your slides.
Yeah. Is it clear now?
That's okay now. Yeah,
yes,
go ahead.
that's it. Yes,
Okay,
that's
thank you
it.
very much.
Good.
Thank you very much.
Great.
So our objective today, we need to address a holistic patient-centered approach, the risk quantification, the old one versus the recent one, 2021. We need to focus on structured educational programs, including principle of nutrition, and we need to recognize the emergency condition as well. So what are the risk factors? The risk factors are categorized into main three groups. The first group is confined to the patient himself or herself, like age, gender, occupation, pregnancy, lactation in female, meal pattern, exercise nature, the motivation, whatever on internal or external, the personal preferences. And the second group confined to the disease itself, which is diabetes, the type of diabetes, the duration of the disease, the diabetic complication and comorbidities, the medicine, whatever oral or parenteral, the previous control, the susceptibility to hypoglycemia, the hypoglycemic unawareness and access to care. And the third group confined to Ramadan itself, the number of fasting hours, the season of fasting, the weather, the geographical location, the social changes, and post-experience. So the old classification focus on into three groups. The first group is very high risk, the second group is high risk, and the third one is low or moderate risk. The very high risk include one of the following. The most of it confined to emergency. So severe hypoglycemia or DKA or hyperosmolar hypoglycemic state within 3 months prior to Ramadan. The history of recurrent hypoglycemia, the history of hypoglycemia unawareness, the poorly controlled type 1 diabetes, the acute illnesses, the pregnancy in pre-existing diabetes or gestational diabetes treated with insulin or sulfonylurea, the chronic dialysis or stage 4 and stage 5 kidney disease, the advanced macrovascular complication. So the recommendation for this group allow not to fast, and we will talk about the structured education program. And the second group, one of the following, the high risk, type 2 diabetes with sustained poorly glycemic control, well-controlled type 1 diabetes, well-controlled type 2 diabetes on multiple drug injection, insulin drug injection or mixed insulin, pregnant type 2 diabetes or gestational diabetes controlled by diet or only or metformin. Stage 3 chronic kidney disease, stable macrovascular complication, patient with comorbid condition, and people with diabetes performing intense physical labor, treatment with drugs that may affect cognitive function. And the recommendation similar to category 1. And the third group, moderate or low risk, one of the following well-controlled type 2 diabetes treated with one or more of the following lifestyle therapy: metformin, acarbaz, second-generation sulfonylurea, incretin-based therapy, SGLT2 inhibitors, basal insulin. And here our recommendation allow to fast, and we need to address the structure educational program. Still, the old one can be used, but we need to focus on the recent one, 2021. It is more precise. It looks like Glasgow Coma Scale. You can save it in your mobile, and you can use it if needed. It consists of 14 elements. And if we look for this figure, we will find the high points confined to presence of hypoglycemia, the macrovascular disease complications, and the kidney disease complications, pregnancy, and cognitive function. So the first element, diabetes type, is it type 1? Give 1 point. Type 2, 0. Duration of the disease, more than 10 years, give 1 point. Less than 10 years, 0. Presence of hypoglycemia. Hypoglycemia and awareness, maximum point, 6.5. Recent severe hypoglycemia, 5.5. Multiple weekly hypoglycemia, 3.5. Hypoglycemia less than 1 time per week, give 1 point, and no hypoglycemia, 0 point. Level of glycemic control, A1C more than 9%, give 2. A1C less than 7.5 to 9, give 1 point. A1C less than 7.5, give 0 point. The type of treatment, the multiple daily mixed insulin injection, 3 points. Basal bolus insulin pump, 2.5. Once daily mixed insulin, 2. Basal insulin, 1.5. Glibenclamide, 1. Gliclazide or glimepiride, give 0.5. Other therapy, not including sulfonylurea or insulin, give 0 point. Self-monitoring of blood glucose, indicated but not conducted, give 2 points. Indicated but conducted suboptimally, give 1 point. Conducted as recommended or as indicated, give 0 point. And the 7 elements confined to acute complications, DKA or non-ketotic in the last 3 months, 3 points. In the last 6 months, 2 points. In the last 12 months, 1 point. No DKA or non-ketotic, give 0 points. The 8 elements is confined to macrovascular disease complication. Unstable, give 6.5. Stable, give 2. No complication, give 0. And renal complications, EGFR less than 30, give 6.5. EGFR 30 to 45, give 4. EGFR 45 to 60, give 2. EGFR more than 60, give 0. And the 10 elements confined to pregnancy, pregnant not within targets, give 6.5. That is high risk. Pregnant within target, give 3.5. And not pregnant, 0. The cognitive function, more than 70 years old with no home support, give 3.5. Impaired cognitive function, give 6.5. No loss in cognitive function, give 0. And physical labor, highly intense physical labor, give 4 points. And this point is commonly occurred in Sudan. And moderate intense physical labor, give 2 points. No physical labor, 0 points. Previous Ramadan experience, overall negative experience, give 1 point. No negative or positive experience, 0 points. And the last 14 elements, fasting hours, more than 16 or equal, give 1 point. Less than 16, give 0 points. So the calculation of these elements, it looks like traffic lights. Low risk, 0 to 3 points. Moderate risk, 3.5 to 6. And high risk, 6 points. So the green one allow to fast, the yellow and the red allow not to fast. So we need a comprehensive medical care before, during, and after Ramadan. So we need the patient assessment, and always remember it consists of 6 A's. We need to arrange an appointment. Yes. We need to arrange an appointment. We need to assess. We need to access. We need to negotiate with our patient a comprehensive medical review and care, and we need to give them the best option then to decide and take their action. And we need to address structural education program. We will talk about it. So our categories allow to fast. This is cat 1, or the record between 0 and 3, and other category moderate and high risk allow not to fast. So our comprehensive management consists of complete history, as I mentioned before. We need behavior, depression, stress, diabetes, stress scale, GAT7, BHQ9, and anxiety, eating, activity, sleeping, smoking, alcohol, or substance abuse. And we need to take a history regarding medications and how to be adjusted. And this will be discussed by our senior in this session. We need the vaccination status, the social support and care, and family support as well. We need examination from head to toe, and we need laboratory investigation, plus EKG and other if needed. So the structured education programs during Ramadan, our goal, better weight. We need to achieve A1C, and that is might be individualized. We need no complication and no hospitalization. The positive outcomes of this program may also extend beyond the months of fasting. So it consists of 6 elements. The first element is quantification. We need to categorization of our patients. And the second element, we need diet control, quantitatively and qualitatively, and the frequency, and encourage fluid intake, always fluid intake. And the third element is exercise, the type of exercise. Of course, this is aerobic exercise, and the time, is it after Isha prayer? Is it after iftar? And the duration, is it 30 minutes, 40 minutes, 50 minutes? And the medicine, we need to review the medicine, modification of existing medication, and lifestyle regime. We need blood glucose monitoring, and blood glucose monitoring, it could reach up to 7 times per day, or 6 times, or 2 times. It depends on the category. For low risk, we can do 2 times per day. For high risk, we can do it up to 6 or 7 times per day, and we can do it if the patient is symptomatic hypoglycemia. And the last elements, when to break fast, and we need to break fast in case of hypoglycemia, and the blood glucose should be less than 70, and in case of hyperglycemia, and the blood glucose should be more than 30 milligram per deciliter, and we need to break fast if the patient, if complaining of symptoms of hypoglycemia, or during acute illness, we need to break the fast. So this is the 10 principle for our nutrition. We need to take 1 or 2 snacks between iftar and just before sahur. And the carbohydrate approximately consists of 45 to 50%, and the fats approximately less than 35%, and the protein between 10 to 30%. And we need to design Ramadan plate methods. We need to avoid sugar. We need to use a low glycemic index, and this is very important. And we need hydration, fluid intake, encourage plenty of water, and avoid sugar as well. And we need to take sahur as late as possible, and this is recommended by our Prophet. Take sahur late as you can, and take iftar as early as possible. We need adequate protein and fat, and this is very, very important. This consume at sahur to induce satiety. Iftar should be begin with water and 1 to 2 dates. And we need to correct this false belief, plenty of water with sugar, asida, tisra, etc. We need to correct this issue. We need just to concentrate on water and dates as far as we can. And we lead to low calories snacks such as fruits, nuts, or vegetables may be consumed between meals. This is created by Harvard. We can use it. This is in Arabic. So blood glucose monitoring, as I mentioned before, blood glucose level should be checked at any time when symptoms of hypoglycemia are recognized. If it is 70 to 100 milligram per deciliter, blood glucose should be done hourly until to become more than 100 milligram per deciliter or fasting is broken. Patients with history of hypoglycemia awareness should have continuous blood glucose monitoring. And this is a time of blood glucose monitoring just before sahur, at morning, midday, afternoon, just 2 hours, just before iftar, and just 2 hours after iftar, and the 7 point if needed, if the patient receive severe illness or if the patient complaining of symptoms of hypoglycemia as needed. So this is sick day rules. Sick day rules means we need to use sugar as far as we can during illness. And we need to monitor our glucose level, and we need to increase the dose if needed. The I for insulin, take insulin as before, or you can increase the doses of insulin if needed, and be aware about SGLT2 inhibitors and metformin, and these can cause dehydration. And the C for carbohydrate, maintain hydration and carbohydrate intake. Unable to eat or vomit, we need advised sugary fluids. High blood glucose, maintain fluid intake with sugar-free fluids, in particular DKA and non-ketotic hyperosmolar. You can add medicine as well. Low blood sugar, regular sugar fluids, and you might reduce or stop medicine as needed. And we need to check the ketones. Ketone can be checked every 2 hours. If it is difficult, it can be at least checked 4 to 6 times per day. And this is sad, man. Be aware about this. Remember acute illness and remember dehydration as well. S for SGLT2 inhibitors, increase risk of developing euglycemic DKA, and euglycemic means blood glucose less than 14 milligram per deciliter. And A for S, and D for diuretic. The ACE inhibitor increase risk of developing acute kidney injury due to reduced renal efferent vasoconstriction, and diuretic also increase the risk of develop acute kidney injuries. And M for metformin, metformin increase risk of developing lactic acidosis. And A for ARBs, it looks like S, increase risk of developing acute kidney kidney injury due to reduced renal efferent vasoconstriction. And N for non-steroid, and this bit false non-steroids are commonly used in our health centers, and it can increase the risk of developing acute kidney injury due to reduced renal afferent vasodilatation. And we need to recognize the emergency condition, and the most common one is hypoglycemia and DKA. The signs of DKA: excessive polyuria, dehydration, shortness of breath, abdominal pain, leg cramps, nausea, vomiting, mental confusion, and drowsiness, ketones in blood or urine, and we know the trait: ketonemia, pH 7.2, and random blood glucose 250 or more. And the second emergency is a non-ketotic hyperosmolar hyperglycemic state, and the random blood glucose approximately more than 600 milligram, typically seen after several days with glucose levels And we can observe disorientation or confusion, polyuria, thirst, and dry mouth, nausea. In the later stage, the person becomes drowsy and gradually loses his or her consciousness. And this is life-threatening condition required hospital admission. And the most important emergency situation is hypoglycemia. Hypoglycemia is a big issue to doctors and to patients. Hypoglycemia can occur during Ramadan fast, during driving and living, sleeping, swimming, work, travel, and during exercise as well. And the causes we know: high dose of insulin or secretagogues, does not eat enough food, vigorous exercise, drink excessive alcohol, and the symptoms we know vary from one person to another. And the early symptoms is sweating, tremor, feel hungry, and anxious. And the classification of hypoglycemia, as recommended by ADA, severe hypoglycemia independent of capillary glucose and requires active assistance, symptomatic hypoglycemia, and the capillary glucose more than 70 milligram per deciliter, and this is self-treated, and asymptomatic, no symptoms, and the capillary blood glucose, less than 70 milligram per deciliter, and this is self-limited as well, and pseudo, this is symptomatic, and here the capillary glucose more than 70 milligram per deciliter, and this is self-limited, and probable symptomatic, this is symptomatic, independent of capillary glucose, and this is self-limited. And the recent classification, blood glucose less than 70 milligram per deciliter and more than 54, and this is level 1. And level 2, blood glucose less than 54 milligram per deciliter, and this is level 2. And level 3, any deterioration in mental or physical finding. So my summary, for those Muslims with diabetes, we need to address a comprehensive medical review and care, negotiate, give them the best options, and let them to decide. Thank you very much for your listening.
Thank you, Dr. Musa, for the nice and comprehensive review. And the chair is now of the session is with Dr. Salaf. Dr. Salaf, please.
Assalamu alaikum wa rahmatullah. Can everybody hear me?
We can hear you very clear. We can hear you very clear, Professor Salaf.
Thank you very much, Dr. Muhammad Bashir, and thank you very much, Musa, for this really comprehensive review on the new guidelines of diabetes and Ramadan. If I may, if my co-chair will allow me, and the presenter just 1 minute to give the participants a review on the diabetes and Ramadan DAR Alliance. Am I allowed, Muhammad Bashir?
Sure, Professor. Yes, please go ahead.
If you may give me the permission, and Dr. Tariq.
Yeah,
Thank
fine.
you
Go
very
ahead.
much. طيب يا اخواننا. Okay. I promise I won't be long. طيب يا اخواننا، شكرا جزيلا. أنا دكتور السلاف إبراهيم عبد العزيز. I'm a member of the executive committee of the Diabetes and Ramadan International Alliance. How this came up, this international alliance started in 2013. Initially, all the Arab countries were working individually, separately, on trying to manage their own diabetes and Ramadan issues. That was since the 1990s. And in 2013, all or some of the Arab countries in the MENA region, the top people who are working on diabetes, they came together in a meeting. It started in Manchester in the winter of 2013. We all sat together and we discussed and tried to put We made this executive committee, and then later on, each person went back to his country and discussed with their societies and came up with their own position statements. Later on, we combined all this together and started working as one, the MENA region on Diabetes and Ramadan International Alliance with the International Diabetes Federation. And when we started the guidelines, which Dr. Musa presented to us, we started with 4 categories. And then our second meeting, we came down to, they were reduced and revised, and we came down to 3 categories. And now the new categories that have been published last year as presented by Dr. Musa. So this is just to give you a review of how Diabetes and Ramadan came out, and the guidelines, how people sat down and formed these guidelines. I thank you very much for giving me this opportunity. And I'd like to present our next speaker, Dr. طارق الهد. Dr. طارق الهد is a very close friend of mine, and هو غني على التعريف صراحة. Dr. طارق, everybody knows him, but I'm honored to present him. He qualified from the Faculty of Medicine, Khartoum University, Sudan, and then pursued higher medical training in the UK. Upon completing junior posts in East Anglia, West Yorkshire, and Staffordshire, he obtained his MRCP in 1992, and then moved to the Royal Infirmary of Edinburgh for specialist training in endocrinology and diabetes. Dr. الهد then moved to the northeast of England at Teesside and then Royal Victoria Infirmary in Newcastle upon Tyne. In 1995, he obtained an MRC research fellowship at Dundee University in Scotland, followed by an MD with a theme of endothelial dysfunction in diabetes. Dr. الهد completed specialist training in general internal medicine, diabetes, and endocrinology with a CCST at the Professional Department of Endocrinology at North Staffordshire Hospital, Stoke-on-Trent in England. In 2000, he was appointed to the first consultant post in the UK at Dundee Group of Hospitals in West Midlands, England. Between 2003 and 2006, he held the post of consultant endocrinologist at King Faisal Specialist Hospital Research Center in Jeddah, Saudi Arabia, followed by a post of consultant physician endocrinologist at Ayr Hospital in Scotland. He was then appointed as a person chair at the University of Medical Sciences and Technology in Khartoum, Sudan, and he subsequently held several consultant posts in the UK before moving to Hamad Medical Corporation in October 2014. He also served as a peer reviewer for several journals, including Diabetic Medicine, Annals of Saudi Medicine, Endocrine Practice, and Clinical Active Medical. He currently serves as an associate editor of the Sudan Medical Journal, and he has been invited to speak at several professional endocrine and diabetes meetings. He has authored and co-authored more than 50 articles in peer-reviewed journals and several book chapters. He is a fellow of the Royal College of Physicians of London and Edinburgh, a fellow of the American College of Endocrinology, and a member of several European and American professional associates. And now, Dr. Tariq, the floor is yours.
Sulaf, thank you very much. You make me feel very humble. This is very kind of you indeed. And thanks again to Sudak and for Sudis to have such a joint venture. And it makes me actually feel again very humble to provide my input into the medical platform of my home country. I welcome you all to this night, and I hope all of us will get the fruits out of it where we will be able to help our patients. كل سنة وانتم طيبين ورمضان على الأبواب وشهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان فمن شهد منكم الشهر فليصمه ومن كان مريضا أو على سفر فعدة من أيام أخرى. I don't have any conflict of interest, but this verse in Surah Al-Baqarah just underscore briefly that actually our patients with diabetes, according to this principle, have got the license actually not to fast. But as we know from research which has been done over the last 2 decades, many patients with diabetes insist on fasting. Actually, according to the Diabetes and Ramadan study done by Ibrahim Salti, published back in 2003, around 85% of those with type 2 diabetes do fast, and 78% of those with type 1 diabetes fast. Of course, we are living in a world where diabetes has mushroomed, and out of a global Muslim population of 1.6 billion worldwide, we have around 148 million Muslims with diabetes. And of course, as my young colleague, Dr. Musa Bashir, has elaborated, fasting is affected actually by the numbers of hours of fasting. And this is very much actually depending, upon the geographical locations. It can range anything between 15 up to 20 hours, depending which part of the globe you are. And of course, hot, humid summer weather, when it comes actually with Ramadan, does add to the risk of fasting Ramadan. The good thing is that we are moving actually, step by step into the more temperate as well as cold climate, even in our part of the world. Musa has actually talked about risk stratification, and we know that there are actually problems, potential problems, I would say, relating to fasting during Ramadan in diabetic patients, and there are protein, and we know all about them. However, when it comes to my talk, I would like you to just consider what sort of patient medication among this risk stratification when we assess our patients. And of course, the characteristics of the patients influence the risk of Ramadan fasting, and the care to be provided to this patient very much has to be individualized, because not every patient is the same. And most important thing is that before Ramadan, and according to the DAR guidelines, as well as the principles of good medical practice, as my friend Sulaf has actually alluded to, the most important thing is the pre-Ramadan assessment and education. And this pre-Ramadan assessment and education has very much to observe certain actually variables. Of course, we have to stratify the risk and develop an individual management plan. We have to consider actually a concurrent Ramadan focused structured education. And my colleague Musa Bashir has actually covered most of these, so I will not go in details, but we should actually have a sort of a focused education before Ramadan, and even during Ramadan, we should have an open access to our patients so that we can advise them. And of course, the focus education has got around sort of 8-9 components, including education regarding fluid intake, blood glucose monitoring, and the most important things, we have to stress our patients when to break the fast, and that they have to know to recognize symptoms not only of hypoglycemia, but again of hyperglycemia. And of course, the management of type 2 diabetes who fast during Ramadan with oral agents is going to be the main theme of my talk. And we know that actually, again, this is very much actually in the heart of the pre-Ramadan assessment. When the patient comes to you before Ramadan and you are advising him regarding Ramadan, you are counseling him, one of the most important things is that you have to look into his medications, and then you have to decide what sort of medications to adjust, what medications to omit, if any, and what sort of medications to be considered well in advance of Ramadan, either to change or to add or to stop. So it is very much important component, the pre-Ramadan assessment. And we know that, the self-monitoring of blood glucose, again, is a very important parameter of actually, monitoring our patients with type 2 diabetes who are on oral agents. And Musa has actually given you an idea what sort of times. I would like just to stress that the most important thing you have to tell your patients to check their blood glucose is to check their blood glucose actually in the second half of the day, i.e. after 12 noon time, because it has been shown by research that this is a time when actually most problems related to hypoglycemia do occur. Of course, by the time I started my research, over a quarter of a century ago, there were only a couple of oral agents to many patients with type 2 diabetes. However, since that time, there has been mushrooming actually of our therapeutic armamentarium, and we do have around 8-9 agents now of oral agents which are available at our disposals to treat our patients. So I will take you step by step on most of these actually oral agents, and I will tell you what sort of advice you need to give to your patients when they start actually, fasting. Okay, right. Let us take, in the first instance, the most commonly used drug, which is metformin. Metformin, we know that, it does not cause hypoglycemia in non-fasting individual patients receiving metformin. It does not per se. It can, it is pretty rare. However, during Ramadan, we have to remember that it can actually contribute to hypoglycemia. And when we come to what sort of changes to metformin dosing during Ramadan, of course, we have to consider what other agents the patients take. But when we take metformin per se, we have to see whether the patient is taking once daily dosing, and if the patient is taking metformin only once daily, this dose has to be taken at iftar, and no dose modification is usually required. On the other hand, if the patient is taking metformin twice daily, there is no need to modify the dose generally, and the doses has to be moved to be taken at iftar and at suhoor. However, I will come at the end to those patients who are actually using multiple and complex drug regimen, which consist of 3, 4, 5, 6 medications. Here, metformin might actually, be considered to be slightly modified, and I will come to this right at the end of my presentation. So, some patients with type 2 diabetes might take metformin 3 times daily, and here, morning dose has to be taken before suhoor, and we have to combine the afternoon dose with the dose taken in the evening to be taken at iftar. Okay, and of course the prolonged release metformin preparations like metformin SR or metformin XR, there is no dose modification, and patient actually can take the whole number of tablets, being 1 tablet or 2 tablets at iftar. Okay, what about acarbose? Acarbose, in my opinion, is an obsolete. I have just put it in case you might come across some patients. Those are the medications which has got actually a sort of a more use, probably in Germany and in other sort of European countries. But in our part of the world, I have seen them actually not being used at all. So we have to remember that these agents, do not have risk of hypoglycemia in non-fasting individuals, and they have got generally lower efficacy than metformin, and their side effects has been very much limiting its use. And I don't think you will come across patients, but if you happen to see patients who are on acarbose, there is no need for any dose modification, and patient actually can take whatever dose they are combined during iftar only. The third group I'm going to focus in is the glitazone, the thiazolidinediones, and of course, the risk of hypoglycemia in non-fasting individuals is very low. However, due to the low risk of hypoglycemia with the only available agent, which is bioglitazone, I'm sure you have it very rampant in Sudan. Likewise, it is quite available and widely used here in Qatar. There is no dose modification required during Ramadan, but the dose should be taken with iftar. There is a couple actually of studies of the thiazolidinediones in patients with type 2 diabetes who are fasted in Ramadan, and it was a single study actually, and there was no significant number of hypoglycemic events. However, the effect overall tend to be actually in addition to other actually effect of other oral hypoglycemic agents, because they are very much important insulin sensitizer, and the risk of hypoglycemia tend to be heightened actually, especially in patients who are taking either insulin or who are on multiple agents. And I will come to this again at the end. And the fourth group is what we call the postprandial glucose regulators like rebaglinide, and rebaglinide is more or less acts in the same way like sulfonylurease, and several studies actually have indicated that the risk of hypoglycemia in fasting patients is quite low. There is one study actually done in Malaysia by Anwar et al., which showed that, you know, in comparison with sulfonylurease, the short-acting insulin secretagogues are pretty safe, and this is primarily actually related to their short actions. And during Ramadan, we have to ask the patients actually to take the dose primarily with iftar, and generally outside Ramadan, patients who are taking these insulin secretagogues tend to take it primarily with each meal. So we have to ask them to take it during iftar as well as before suhoor, and maybe we have just to consider reducing the dose slightly with suhoor. But with iftar, there should be no problem actually with combining the two doses of the morning and the afternoon. So the fifth agent is the glucagon peptide receptor agonist, and my colleague and friend Dr. Ibrahim Ma'mon is going to talk to you about insulins. These are injectable agents. They are pretty safe, and we do have actually several agents available in the market, and they were actually studied by several groups during Ramadan. The risk of hypoglycemia is quite low, but it could be quite actually high when you combine it with other agents, especially sulfonylurease. And the agents available are liraglutide, lixisenatide, and exenatide. And the dose of these agents has to be well titrated, actually well in advance of fasting Ramadan. But during Ramadan, these agents can be taken actually, you know, at iftar, and there is no specific actual requirement for any dose modification. Several studies actually has shown that they are pretty safe during Ramadan. The other group, which is related to the GLP receptor agonist, are the DPP-4 inhibitors. Those agents are very widely used. They are available in many countries. They are actually used in combo preparations. They can be used with metformin, and they have been actually used with other agents. They were widely actually studied in patients who are fasting Ramadan. There are several publications since the last 1.5 decades. And the overall take-home message is that the risk of hypoglycemia from these particular agents is very low. And this is actually applicable to all agents ranging from sitagliptin, vildagliptin, saxagliptin, allogliptin, and linagliptin. They do not require dose modification when they are used alone. However, again, when we come to the issue of multiple agents, we have to revisit this, and I'm going to show, as I mentioned before, at the end of my talk. The most important agents are the sulfonylureas. I have left them to the last part of the oral agents because the risk from these agents of hypoglycemia is very high than other antidiabetic agents. And this is primarily related to the mode of their actions. They are insulin secretagogues, they are very powerful. And, you know, certain agents, especially the first generation sulfonylureas like glibenclamide, are very notorious actually of triggering hypoglycemia with fasting. And now there is general recommendations that these agents should not be used, especially in patients who are elderly. However, when you have a special situation, possibly in Sudan, where the availability of medications is not that actually very good, you will find many patients actually taking this agent. So you have to pay special consideration for those adjustments. I will come to this because studies have suggested that despite class difference between various agents ranging between glibenclamide, gliclazide, glimepiride, and glipizide, the risk tend to be higher with glibenclamide and far less with the short-acting second-generation sulfonylureas, especially gliclazide and glimepiride. But again, the dose adjustment has to be very much considered. And again, we have to consider patients who are on multiple agents. So I won't go, because of sake of time, over the sort of various studies, but there are well studies actually, including the special preparations of the gliclazide MR. So what do we advise our patients who are on sulfonylureas? Fair enough, as I mentioned, number one, we have to avoid using the old generation glibenclamide, but if patients are taking it, we have to pay special consideration. However, whenever feasible, we have to play safe. Patients has to be using second generation of sulfonylureas. This is primarily gliclazide, especially the MR, the modified release preparations, as well as the conventional gliclazide and glimepiride, because there are short-acting, they are preferred over the older classes, such as glibenclamide, as I mentioned. So when the patient is taking a sulfonylurease agent once daily, they have to take it at iftar, and in individuals with well-controlled blood glucose level, the dose may be reduced. I have to stress that what I'm presenting here is according to the DAR Alliance guidelines. This is endorsed by the International Diabetes Federation, and we have to take it actually for granted. Patients who are taking twice daily dosing, the iftar dose remains the same, but in individuals with well-controlled blood glucose levels, the sahur dose should be reduced. And even sometimes you might have to omit it completely. So those who are using older drugs of sulfonylureas like glibenclamide, these carry high risk of hypoglycemia and they should be avoided. However, if you cannot avoid it, you have to ask the patient to reduce the dose generally. And if the patient is elderly and greater than 65, you might have to consider actually of reducing the dose drastically or even stop it completely if the patient is taking other drugs. If the patient is taking only glibenclamide, you can actually reduce the dose by a minimum of 50%. What about the newer agent, the sodium glucose cotransporter 2, the SGLT2 inhibitors? Again, outside Ramadan, SGLT2 have a low risk actually of causing hypoglycemia. They have, as Dr. Musa Bashir has pointed to, high risk of dehydration and acute kidney injury, and they should be only used in circumstances of significant volume depletion. So you have to advise your type 2 diabetic patient that they should actually take enough fluid. They have to take extra fluid when they are on these agents. And if it happens that there is situations of volume depletion such as vomiting or diarrhea and concomitant use of other drugs like ACE inhibitors and diuretics has been pointed out by Dr. Musa Bashir, we have to remember that these agents can cause acute kidney injury and they can trigger hypoglycemia. And from our clinical experience actually with these agents, when they are used in combinations, they can actually trigger hypoglycemia. We do not need to reduce the dose in patients with type 2 diabetes on these agents who are fasting Ramadan, but we have to be very precautious and we have to advise patients about these certain precautions. There are various studies, they have been well actually studied inside Ramadan. There are various publications, especially from the group of Muhammad Hassanin and his group in Ramadan, as well as from another group in the Far East in Malaysia and Indonesia. So just sort of general focus again on SGLT2 because it could be quite actually notorious in causing problems. As I mentioned, fluid intake has to be maximized. We have to look into other medications and we should actually educate our patients about their various risks and we should monitor patients. Finally, just I would like to focus on what we call the ProFast project because we were credited here in Qatar and credit actually goes again also to all my collaborators. We looked into patients who are on multiple agents, not only actually oral agents, but patients with type 2 diabetes who take multiple agents during Ramadan, who are fasting. We studied them actually extensively, and we have made several publications. And we am going to give you actually what sort of advice you need to tell these patients where actually the recommendations in the last 2021 IDF-DAR guidelines has been published. This has been included in these sort of guidelines. So the ProFast project is well publicized. There are various papers actually looking into the incidence of hypoglycemia in patients who are taking multiple oral agents. And I will tell you more how to actually adjust the dose of various agents. And we have combined actually study of these patients by some means of technology where actually Muhammad Bashir came with the idea of utilizing the freestyle library, the flash continuous glucose monitoring. And we have published actually paper several years ago in this particular group of patients. And we also, looked into patients who are on multiple agents before fasting and during Ramadan, where actually we looked into them before Ramadan without actually knowing their medications. And again, actually before Ramadan, after knowing their patients, giving them advice to adjust it. And we found that actually when you approach these patients in this particular manner, you tend to mitigate the risk of hypoglycemia completely in these patients. And this has been very much actually proven by the technology of the freestyle library. Not only that, we have moved one step further and we are still actually experimenting we actually applied the principles of artificial intelligence, where we are trying actually to devise a model where what sort of medications, your age and your other clinical variables can be actually used to generate specific model where you can predict actually risk of glycemic excursions like extreme hyperglycemia as well as hypoglycemia. And we are continuing to do this. So I will go back to tell you that patients with type 2 diabetes who are actually taking multiple anti-diabetic agents stemming out from some other studies as well as from the ProFast. This has been actually taken and been incorporated in the DAR IDF guidelines. Here are the considerations and recommendations for patients who are taking minimum 3 agents or more. Many individuals on multiple anti-diabetic agents, they do have a long duration of diabetes, as we know. The more complicated and more duration of diabetes you are, the more actually you need more medications. And of course, no wonder that these patients do have multiple comorbidities as well as renal impairment. Then the risk of this particular group of patients is very high. So these patients in particular, they have to receive special consideration when you consider the pre-Ramadan self as well as risk stratification and assessment. They have to get a comprehensive advice on diet, lifestyle, and those who are taking 3 or more drugs combination, especially when it involves insulin. I'm sure Muhammad, I'm sure Ibrahim Ma'mon will talk about the insulin adjustment in this particular context, but because insulin as well as sulfonylureas, when they are used actually in complex and multiple drug combinations, these patients will have very high risk of hypoglycemia. Therefore, we have to consider at least 25 to 50% reduction in the dose of sulfonylureas as well as insulin, and primarily of insulin. And of course, Ibrahim Ma'mon, my colleague, will talk to you about this. The reduction in the dose of the sulfonylureas is also advocated, but in our study, we have generally actually reduced the dose of sulfonylureas by 50%. And of course, we have to try whenever feasible to employ the newer technology, including the continuous glucose monitoring, in order to avoid hypoglycemia in this particular group of patients. And of course, when Ramadan is over, it is not over. We have to go again for post-Ramadan assessment. And there is a need actually for the healthcare professionals to have assessment of the individuals again, where we advise them regarding what sort of changes they have to make according to their Ramadan experience. And we have actually to give them actually the chance of having safe Ramadan in the future. So pre-Ramadan assessment, in summary, is very vital for many patients with type 2 diabetes. And there are advantages and disadvantages associated with different treatment options with people with type 2 diabetes who are fasting during Ramadan. Those who are taking metformin, sulfonylureas, insulin secretagogues, or insulin will need to take dose adjustment when we are considering hypoglycemia. However, patients who are on multiple anti-diabetic therapy will find themselves at greater risk. But patients who are on single agents, when it involves metformin, DPP-4 inhibitor, or even SGLT2 inhibitors, they actually can be advised to keep fasting, but they have to adopt certain precautions. And of course, you know, the post-Ramadan follow-up is very important because Ramadan keeps coming every year. And with the correct advice and support from the healthcare professionals, most people with type 2 diabetes nowadays can fast safely. كل سنة وانتم طيبين, and I will stop here, and I would like just to acknowledge actually my co-authors in the section of management of type 2 diabetes in the practical guidelines 2021, which I have been actually honored to be one of the co-authors. Great tribute to Dr. Wasim Hanif from Birmingham, Muhammad Hassanein from Dubai, and Dr. Nazir Ahmed from South Africa. Thank you very much, Mr. Chairman.
Okay, thank you very much, Dr. Tariq. Dr. Salaf, you're muted.
Yes, thank you very much, Dr. Tariq. That was a fabulous talk, as usual. Magharib alayk. Thank you, excellent, very nice review. And our last speaker, I will hand over to Muhammad Bashir to present him. Thank you.
All right, thank you very much. And our last speaker is Dr. Ibrahim Ma'mon. Dr. Ibrahim is a graduate of the University of Khartoum, and he's a senior endocrinologist with over 20 years of experience. Dr. Ibrahim has completed his training in the United Kingdom and obtained an MD, PhD from Newcastle University after defending a thesis titled The Genetic Basis of Insulin Resistance and Cardiovascular Disease. He started his consultant's career as a consultant in Durham in the UK before moving east. And finally, he joined Sidra Medicine in Qatar as a senior attending physician in endocrinology in May 2017, and is leading the service of diabetes in pregnancy in the hospital. Dr. Ibrahim is also examiner with the Royal College of Physicians and has been actively involved in teaching of both undergraduate and postgraduate, and served as an overseas regional advisor for the Royal College of Physicians of Edinburgh. He's also an assistant professor of medicine with Weill Cornell University in Qatar. Without further ado, Dr. Ibrahim, the stage is yours.
Thank you, Muhammad, for the nice introduction, and Sulaf, Sudus, and Sodak for the invitation. Being given the title of how to manage our patients who are taking insulin and still wants to fast Ramadan, and given a 20 minutes to present that. So can you see my slides?
Yes, we can.
I have nothing to disclose. As you all know, that fasting is an important part for many religions, not just Islam, across the globe. As been mentioned by Dr. Mousى, that the duration of fast, the number of days, and the type of fast varies greatly across religion. And us as a healthcare provider treating people with diabetes, we need to understand the impact fasting Ramadan will have on our patients' diabetes care. Improving on this, this can lead to improve our skills, and we can manage our patients safely who wish to fast. I will start with a case study as a background. It's got a 58-year-old man who attends a clinic, and he's been doing it in the right way, that he came to see you 2 weeks before Ramadan. He's an engineer who had diabetes for 11 years. He's currently on sitagliptin metformin combination, 1,000 over 50 twice a day, glycoside slow release 120 milligram per day. He's been started on glargine in the last 6 months, and he's currently on 24 units. His recent HbA1c is 7.3, indicating an optimal glycemic control. He generally tends to check his fasting blood glucose before breakfast, and it ranges between 9 to 230 milligram per deciliter, and he tends to do that every other day. He's got a normal renal function. Blood pressure is normal with a BMI of 28. He has no cardiovascular disease, but a mild peripheral neuropathy. He fasted without any problem last Ramadan, and he's keen to do the same for this Ramadan. However, he's concerned that he's been on insulin in the last 6 months, and he might develop hypoglycemia. In general, he tends to be free from hypoglycemia, apart from the days where he's been busy and he's missing meals. He's independent, lives with his wife and 2 daughters. So the key question, the key challenges here would be whether to fast or not to fast, and it's been illustrated nicely by Dr. Musa and repeated again by Dr. Tariq about the risk stratification and this currently assessing the current risk of this gentleman fasting. Also, the key element here is how to minimize his risk of hypoglycemia if he fasts Ramadan, and what advice or consideration will you provide him? As been mentioned by Tariq earlier, that despite the fact that we get our guidelines about who at a very high risk of fasting and should not fast, and those who are high risk, still there was been documented that majority of Muslims with type 2 diabetes fasted every day during Ramadan. And in this study that in type 1 diabetic patients, nearly 50% of patients fasted every day during Ramadan, and about 72% fasted at least 15 days. And the same is even higher in patients with type 2 diabetes. We know that Ramadan will have the sleep pattern will change, also the meal times. And we know from the physiological changes are most marked in countries at a higher altitude with more daylight, and this can have an impact on the blood glucose, also have an impact on the decreased total sleep time, the delayed sleep, the decreased sleep period, and decreased rapid eye movement sleep duration. It's also been shown in the CGMS study, there was the blood glucose levels rise rapidly after iftar in patients with diabetes. And although there was no difference in the number of glycemic events during Ramadan compared to pre-Ramadan period, however, there was a major intra-individual variability in the continuous glucose monitoring profile were observed, in particular, the rapid rise in blood glucose after iftar. This is the slides being shown earlier that the key risk associated with Ramadan fasting are dehydration, hypoglycemia, hyperglycemia, which might lead to diabetic ketoacidosis, and this can be exacerbated during summer fasting and hot and humid conditions. It's been documented that from the Diabetes and Ramadan International Prospective Study that when they looked at the incidence rate of hypoglycemia before and during Ramadan among patients with type 2 diabetes, that the incidence of hypoglycemia, whether it's confirmed or severe, tend to double during Ramadan, 9.8 compared to 4.9 before Ramadan. And this was replicated again in the CREED study. Also from the CREED study, it was shown that the incidence of hypoglycemia during Ramadan for individuals who had no episode of hypoglycemia before Ramadan, that's the black bar, and compared to individuals who did have an episode of hypoglycemia before Ramadan, the gray bar. And I think this is a very important piece of information to share with your patients and to get them assessed before Ramadan and looking at the history. The same is actually the risk of diabetic ketoacidosis, as evident by the prospective multi-country observational trial, which compared the incidence of DKA in Sha'ban, Ramadan, and Shawwal. And what it showed that there's a higher rate of diabetic ketoacidosis during Ramadan compared to Sha'ban. And in Shawwal, diabetic ketoacidosis admission were actually higher compared to any other average months. Also, there's a longer duration of acidosis and hence more stay in hospital in the Ramadan group. And this tend to be higher in the longer duration of diabetes. As been shown and earlier and discussed by Dr. Musa and Dr. Tariq, that many patients, despite this, do not receive any structural education. And this is a call for a formal pre-Ramadan education in which we need to reinforce the need for advice against fasting in patients who already experienced DKA in the months preceding Ramadan. The guidelines, which has been recently updated on the practical guideline on diabetes and Ramadan. You've seen this slide before, but I think the key element on the key component of Ramadan focus education program, not only risk quantification, but I think getting the message across to your patient is when to break their fast. This has been shown in a study where they looked at the impact of daytime hypoglycemia, and in particular that only 2/3 of the patients who develop hypoglycemia actually break their fast, while 1/3 continue their day despite having hypoglycemia. So it's quite significant. Again, this is the slide, you've seen it before, and the key element is the individualization of treatment is the key to success of managing patients with diabetes during Ramadan, and this should be continue, started before Ramadan, during Ramadan, and continue after Ramadan. So in this part of the presentation, I will be having 5 case studies, briefly looking at all possible scenarios. The first scenario will be patient on oral medication and insulin. This is the same patient I started my talk with, a 58-year-old with type 2 diabetes for 11 years, who's in Janumet and gliclazide, and who's started on glargine 6 months ago, as HbA1c of 7.3. We can agree whether it's high risk or very high risk, but the patient, most of our patients will still continue to fast, and I think we need to guide and help them across this. The key is education and continue monitoring these patients, having a contact either with a form of diabetes education or a phone consultation, or nowadays with even the WhatsApp, getting in touch with them in the first few days of Ramadan after they fast, getting them prepared before that. So in this particular patient, the 2 key elements here are the combination of insulin and sulfonylurea, and they both impose a risk of hypoglycemia. Regarding the glargine or the Lantus, this is a basal insulin, long-acting. So instead of having it at bedtime, we advise the patient to take it with iftar. We can start with a 15 to 30% reduction in the dose of the basal insulin, and adopt what we call a titration schedule, that every 3 days we titrate up and down depending on their blood glucose level. If they have a fasting, that is just before the Maghrib, if their blood glucose is below 70, we need to reduce the dose by 4 units. If it's between 70 and 90, we need to reduce the dose by 2 units. And if it's between 90 and 120 milligram per deciliter, we continue on the same dose. If it is greater than 120, between 126 and 200, we increase the dose by 2 units. And if it's greater than 200, we increase the dose by 4 units, and we keep titrating this. However, in this particular patient, I think the risk comes from the sulfonylurea, especially the long-acting sulfonylureas, as mentioned by Dr. Tariq. And sometimes the combination of insulin and sulfonylurea can be tricky, because with insulin, they tend to be shorter in action. However, this sulfonylurea can be a little bit tricky. And if we're in doubt, we can always reduce the dose of the sulfonylurea by 25 to 50% of their current dose. So in this case, be aware of the sulfonylurea, reduce their basal insulin by 15 to 30 30% of the units. So that would be 4 to 6 units from 24, titrate every 3 days using the titration algorithm. Second case, patient on a pre-mixed insulin. This is a 45-year-old female teacher with a BMI of 27, blood pressure is 130/74. She's got a diabetes for 16 years. She's got a longer duration of diabetes. And as you can see that she developed diabetes at the age of 29. And for this particular patient, apart from the hypoglycemia, we need to be aware, given the longer duration of diabetes and the younger onset diagnosis, this might be insulin deficient. And not only the risk of hypoglycemia, but also the risk of hyperglycemia and ketoacidosis. She's on metformin and mixed start or Novomix with any pre-mixed insulin, taking 40 units in the morning and 20 units in the evening. She had evidence of macrovascular complication of background diabetic retinopathy. So in general, she's a very high risk, but despite that, she insisted to fast. I think we need to continue giving the advice that she needs to know when to break the fast. We need to make the message very clear that she needs to check her blood glucose on a regular basis, as mentioned earlier, maybe 4 to 7 times according to availability. And most importantly, for the insulin, she will mix insulin. So the timing of the morning one can be changed to the iftar dose, and the evening dose will be sahur dose. So she will take 40 units with iftar, and we need to reduce her sahur dose to by up to 50%, and then titrate. I think I need to mention a very important point here is that, for example, people in the Gulf, the way of the eating habit during the evening can be totally different from people in Sudan or in Egypt or in the other MENA region. Some people will have a very small, light iftar, and then they tend to have another proper iftar around Tarawih time or just before that, while having very light sahur. And in that case, you need to adjust your insulin according to their bigger meal and the habits of the patient. So it is very important not just to change their morning dose to the iftar and sahur, but also looking at the pattern of their eating pattern of each individual patient. Nowadays, we don't have many higher mixes, but Humalog Mix 50 could be a suitable substitute and can cover such patients, especially those who have a very high meal and there is a risk of developing hypoglycemia later on during the day. That could be an alternative. In some particular patients who are deemed to be very unstable and on the mixed insulin, and I've seen them before Ramadan, one of the options I could change them to multiple daily dose injection with a long-acting basal insulin and meal insulin, which can be easily titrated and managed during Ramadan. Our third case is a patient on multiple daily dose insulin. This is a 56-year-old male laborer with BMI of 28, blood pressure normal at 128/70. He had diabetes for 12 years on metformin and glargine 30 units at bedtime and 6 to 10 units of novorapid each meal. He has no macrovascular and macrovascular complication, and he's been managing his diabetes over the years with excellent control at 6.7%. The key element in this case is actually the job of the patient, that he's a laborer, and relatively tight control with 6.7%. And the patient is with multiple daily dose insulin. So there's a higher risk of hypoglycemia, and I need to discuss with the patient the importance of regular monitoring and management of hypoglycemia when to break the fast. So for the basal insulin, I will still apply the same principle as the first case, that I will make a reduction of 15 to 30% of the dose. In this particular patient with the tight HbA1c of 6.7, will be reasonable to reduce the dose by 30% initially. That's about 9 units. So I could go down to 22 or even 20 units of Lantus at iftar time. Considering the quick or the meal insulin, I will look at the main meal, that probably the iftar in our part of the wedding, maybe in Sudan. I will give the higher dose of 10 units, the usual dose, and then with sahur, I probably will give a reduction of 25 to 50% of the meal insulin. However, some patients with sahur might be very light, but they will have a bigger meal around just after midnight, and in that case, I might be giving 80%, 75% of the dose with that one, and omit the sahur dose. So probably we'll end up having two meal insulin. The higher dose will be with iftar, if the iftar is a main meal, and the other one with the second main meal, where that is around 1 o'clock in the morning or sahur time. Fourth case is patient on insulin pump therapy. I think these patients generally are type 1 and should be advised against the not to fast. And if they are fasting, I think we need to use the technology with the advances now with the continuous glucose monitoring, having the freestyle Libra flash monitoring will help patients to see the risk of hypoglycemia, and they will see a trend of the arrow going down. That means they will be having hypoglycemia, and it's be reasonable to stop the fast. The main changes I will make for their insulin is with insulin pump. We have the basal rate and these boluses. For the basal rate, the general advice is to reduce the basal rate 3 to 4 hours before iftar. And for the after iftar, usually will be a peak in the blood glucose. In that case, I will increase the basal rate by about 20 to 30% 1 or 2 hours after iftar. For the boluses, generally I would apply the same principle of carbohydrate ratio to the same way patient is having. However, if the insulin pump has got the capability or facility of having a squared boluses, I might be using this, especially with the staggered meal. So some of them will have the drink and then go on prayer and then have their iftar. In that case, I might be using the square boluses to cover that. Our last category is pregnant women with insulin. Again, these patients should not fast for the obvious reasons. They carry a very high risk, not only for themselves, but also for the baby. During pregnancy, general advice is to keep the blood glucose in a tight range to prevent complication for the mother and for the baby. And we aim at a target between 70 to 140. That's the 1 hour blood glucose should be below 140, which can be very difficult to achieve during pregnancy. Even those with diabetes without insulin treatment can be very difficult to reduce the risk of hyperglycemia, because the time of iftar and the evening is very short, and you have to, it's very difficult to eat 3 different meals. Again, during early pregnancies, there's a risk of increased nausea, vomiting, hyperemesis, and again, that could have an impact on recurrent hypoglycemia and fluctuation in blood glucose. Later on during pregnancy will be the kicking off the insulin resistance, and that can be very difficult to control the blood glucose. So this is the insulin and Ramadan guidelines I was alluded to, talking you through the adjustment you need to do, whether the patient is taking long-acting or intermediate-acting insulin, rapid-acting or short-acting meal insulin, or they've been on the pre-mixed insulin, whether they've been taking it as once a day or twice a day. And this is the dose titration algorithm I was alluded to earlier on, and how to adjust their insulin doses. And that should be done on every 3 days, 3 to 5 days. And we should be in touch with our patients through the diabetes educator, setting up a phone, regular phone contact, or even through WhatsApp group, making sure that the patient are aware of adjusting their insulin. Again, the guidance also talked about the insulin pump therapy. So in summary, I think individualized Ramadan specific treatment regimen should be provided for each patient. This should be sensitive to the region and the cultural factors. Education, communication, and accessibility are all critical to success of whatever guidelines we publish. I think unless we have education and communication and accessibility to care, this cannot be of any impact. I think as Dr. Tariq had alluded to, I think we should be more proactive in having our research, which is specific to our population. I think we need to see more in Sudan, and is required, because that will increase our understanding of the diabetes in Ramadan, and will provide safety for diabetes and Ramadan. And that will end my talk. Thank you very much.
Thank you, Ibrahim, for a very, very, very nice talk and overview. So may I ask all the speakers to open their cameras and join the discussion panel. I can. Okay. So everybody can, if you would like to ask a question, you can press down on reaction and then raise your hands, and then we are gonna, you can unmute yourself and ask any questions you want to the panel group. And till we have some questions, I can see some questions coming. Can I just ask my co-chair, Dr. Salaf, a question about the practicality?
Yes, go ahead.
About the practicality of education sessions. So the education sessions have shown to improve and empower the patients to fast. However, the data came from Western countries mostly. A number of Muslims, they are limited. They are able to get in a small town, get 10 to 15 Muslims, put them together, educate them beforehand. But how practical is this in a majority Muslim countries? And is there any other way to tackle this problem?
Well, definitely, this is a very important issue. The practicality of getting the diabetes patients together in group education meetings. This is very, very important. And with at the beginning of the DAR International in 2014 and 15, we did a study called the DAR Safa study. DAR Safa, SA for safe, FA fasting, for safe fasting. And it included educating patients. Unfortunately, we haven't published it yet, but it's going to be published. Educating the group of patients and then testing what happens to them during the month of Ramadan. We did it in several Arab countries, but our own one in Sudan, will be publishing it soon. So what we really need to do is that we need to talk to our patients a long time before Ramadan. Sometimes patients come a day before Ramadan asking about fasting. This is very short notice, too short notice. What we advise is that at least 2 months before Ramadan. So what we do here in Sudan is that we have decided, we all remind each other in the society, in the Diabetes Society and SUDES, that Ramadan, we have 2 months to go. What we do in our clinics is that we start asking, we are the initiative for the patients, not the patient, because the patient won't remember Ramadan unless a day or two before Ramadan. And then he says, oh, I want to fast. I didn't tell my. So the initiative starts from us as physicians, 2 months before Ramadan. This is a very important practical tip, which we found to be very helpful. 2 months before Ramadan, we start our patient group education in the clinics. We start with the diabetic educator and the dietitians. We start even our meetings like this meeting, we started 2 months before Ramadan. And with the societies, with the drug companies, they help us to do our meetings, even at a smaller capacity and even at a very large capacity meeting. We also we do tutorials in the hospitals with the registrars regarding diabetes and Ramadan, even 2 months before Ramadan. So we get a good, and even the patients, they get a good view of what is going to happen to them. Each patient knows if he's going to fast or not. Each patient knows how he's going to fast. And one of the most important things is sitting with the dietitian, because as has been alluded to by our elegant speakers, is that during Ramadan, people, the type of food changes. عندنا هنا في السودان وفي انتوا اكيد هناك بيجيكم الحلومات. It is one of the very important questions. يا اخواننا الحلومات ده ممكن نشربه في رمضان ولا؟ طبعا بيتعامل بالزريعه والزريعه fermented and it has very high calories. We even with Sister Khitma الله يطرح بالخير, she's a very active dietitian and diabetic educator who works with us in the section of diabetes and a dietitian, the type of food we need to eat during Ramadan. حتى we even formulated with a number of dietitians we have here locally in Sudan exactly how many طرقة كسرة العيش قدر شنو، كمية الحلمر. If you ask patients, if you tell patients don't drink حلمر in Ramadan, they just laugh at you and they will drink it with sugar. What we advise them to drink just 1 single cup a day with no sugar. Okay, just يعني you have to compensate. أيوة. Our group education is very good. يعني it's a very successful approach, and it is very feasible and doable. And then one of the important tips is to ask your patient his experience the previous Ramadan, because sometimes you get patients who are in category 1 and 2 not supposed to fast. They insist to fast. ويقول لك صمت رمضان اللي فات وما حصل لي حاجة. And you go through with them exactly what happened. Okay, you can fast. You have to help him because he insists, even if he's category 1 and 2, يقول له ما يصوم حيصير وحيمشي يصوم. So you have to help him to fast safely. Okay, for these are gray areas, not like the straightforward scoring system we have. There are a lot of gray areas. We have type 1 patients with type 1 diabetes. They insist to fast and they develop DKA. So you have to help them through fasting, especially in Saudi Arabia. I remember when I was working there a long time ago, we had this challenge of patients with type 1 insisting to fast. And remember, the time of fasting is different. The type of food they eat is different. So you have to try to negotiate with them how to fast. And then you have patients in category 3 who can fast, who don't want to fast. Why? Because they had a bad experience the previous Ramadan. Yes. So there are gray areas, not the black and white areas we just saw during the presentations. So group education is very, very important, and it is very effective.
Sure. Thank you very much, Dr. Salaaf. I can see one question coming over here, which says, and I think I can't see Tariq and Dr. Musa. Ibrahim, if you want to take this, they're saying about that we notice our patients to complain of severe hypoglycemia post-iftar. They're talking about post-iftar hyperglycemia, and the blood glucose can shoot as high as 350 milligrams per deciliter. I cannot see Dr. Tariq here. Yeah, I can see Tariq here, and I'll bring Tariq after you finish, Ibrahim, to this question.
Okay, so obviously we need to see what the patient is on medication, insulin or oral medication. But as I showed in that study, where it showed that there is a peak after iftar of blood glucose, and this is why we need to tackle the post-iftar hyperglycemia. As been mentioned earlier by Sulaaf, we need to look at the what they eat for iftar and whether that can be broken, cutting down all the juices and all the sugar stuff, looking at the diet and the key change in the diet. If it's not entirely due to diet and the diet is being looked at, we need to modify their medication, whether the patient will need some sort of meal insulin, with that insulin they're not already in insulin, and this all depends on preparing the patient before Ramadan. So again, back to the education, pre-Ramadan counseling, looking at the different aspects of the education, from the diet, what they need to have in their plate for iftar, how to adjust their medication. But the general advice again is education, making the patient aware on the glycemic index of different food and their impact on their blood sugar.
Dr. Tariq, you want to make any comment? Yeah, please, Dr. Islam.
Well, I can't agree more. I think the most important thing to remember is that postprandial hyperglycemia is a regular feature in patients with type 2 diabetes. However, contributory factors, as alluded to by Ibrahim, including what type of medications, what type of diet patient is taking, does play. But from our research, myself and Muhammad Bashir, we have done with the freestyle library, you could see, clearly that almost exclusively in every patient that the blood sugar tend to shoot actually immediately after iftar. And we know that, as Muhammad Hassanin loves to say, fasting and feasting. إحنا في رمضان الhabit حقتنا in our part of the world, بعد الإفطار مباشرة، I mean مع الإفطار مباشرة, the way we consume food is very actually, you know, something has to be very much looked into, and we have to focus on this in education. فالadvice regarding a diet زي ما تفضل ابراهيم مأمون is very important, and adjustment of medications has to be, and I think more or less it has been covered by Ibrahim. Thank you.
Dr. Salaf?
Yes, if I may add, what we usually advise our patients is, first of all, to break the fast by drinking water, just plain water, and taking 3 dates, okay? And then going to pray, al-Maghrib, sallu. This gives a chance, because the dates will increase your blood sugar, will give you some energy to pray. And then you go on gradually try, next thing after praying, you sit down and try to eat things with, food with a higher glycemic index. That is, it raises the blood sugar gradually and for a prolonged time. بعديها الناس هنا في السودان لأنهم بياكلوا البليلة وسلطة الروب، بنقول لهم مثلا تاخذوا من محددين الكوباية بالمقاس، كوباية الملبن نصها يا إما بليلة يا نصها سلطة روب. For these, if they try to more or less follow this type of diet, they will more or less try to continue to control their blood sugar. But definitely the postprandial hyperglycemia is بتحصل. لكن we can reduce it again, as has been said previously. The other thing is, sorry to interrupt you, but
sorry guys, did I lose Dr. Salaf or we lost her?
During Tarawih, exercising. Yes. So قبل التراويح, we ask them to try to take a snack, a piece of fruit, apple or an orange before Tarawih, because Tarawih is exercise and they may go into hypoglycemia. Again, they have to take care of this.
That's
exactly. This is a
very
key
nice
point. Sorry.
Yeah, go ahead. I was going to ask you, Dr. Musa, if you have any comments. Please go ahead.
Yeah, I strongly agree. This is our bad behavior. We should change it. We need to educate our families in Sudan, but in particular in Sudan, because as you mentioned before, they start how many dates after iftar? I'm sure more than 5 dates. And how many cups of fruits and of very sugary fruits. So diet control and the 10 principle of diet control on medical nutrition and therapy is a crucial key for our diabetic patient in Sudan.
Sure. Thank you very much. And if I may just add here is that the data that came from the Gulf area, I'm not sure if we did this in Sudan to quantify how much calories are there in iftar, but the amount of calories consumed over a short period of time exceeds the ability of a normal person, let's say somebody who doesn't have diabetes, to metabolize glucose. So the amount of calories consumed is higher than what a normal person can metabolize. So even a non-diabetic person with the amount of food consumed will actually battle hyperglycemia based on that, the amount of food consumed. And this is, and again, it's all to do with habits and sugar that's being consumed. So I have another question here, and I think it's going to come over to Dr. Tariq Al-Had here. It's talking about elderly patients, and well, I have to assume I don't know what elderly means because it could be above 70, above 65. But anyway, let's take an elderly patient above 65 who has a high risk of hypoglycemia and insists to fast. He's on metformin 1 gram twice per day, and he's taking gliclazide or diamacron 60 milligrams twice daily. What do you advise such patients? Well, the Muhammad Mujahid said elderly is 70 years of age.
Okay. Muhammad, thank you very much. If I may, have my excuse. Just I would like to make some comment للأخت سلاف going to what we have been discussing regarding the Sudanese diet during Ramadan. Sulaf Osama Hamdi, professor of medicine who has special interest in nutrition and diabetes. And he's a regular, actually, sort of attend as well as, he has contributed to the DAR guidelines. It might be a good idea if you might actually formulate a sort of a common Sudanese diet during Ramadan, and you send it to him and you ask him what sort of advice he can devise actually, because he has devised actually model diet for various sort of Arab countries. Sudan, unfortunately, not included. So I can actually give you his phone number as well as his email. It would be a good idea if you could just tease out what sort of general diets the Sudanese eat, and then you can send it to him. Back
Excellent,
to the question,
excellent.
Muhammad.
Thank
Yeah,
you.
Thank you, Salah. Back to the question of Dr. Mujahid. Thank you very much. I think this is very relevant, and it falls actually in the category of patients who are on multiple drug therapy. Despite that the patient is taking sulfonylureas and metformin, but it is multiple doses and it is high dose and he's elderly. So very likely he will have an element of mild renal impairment. We know that EGFR by age tend to go down, and fasting during actually, especially those days still we have this summer, tend to be quite prolonged, up to 15 hours. So what will happen is that this patient might have accumulation of his sulfonylureas, and this will put him at high risk of severe hypoglycemia. So ideally the dose has to be reduced by 50%. So I will chop off the second dose of gliclazide. I will ask him just to take 1 gliclazide with iftar. Not only that, 2 grams actually of metformin might actually be too much during those days in this particular patient. So ideally he should take 1 gram with iftar plus gliclazide, and possibly it might be a good idea if he takes actually light suhoor, okay, either to have the dose of metformin or just to omit it and see what will happen. And I'm sure, you know, his overall safety profile will be very much heightened. Thank you very much. That's very interesting.
That's nice. There is one of our colleagues, Dr. Abu Bakr Abu Midian. He's from the UK, and he is asking the group for an advice regarding research. He said, we are running a study in the United Kingdom about fasting and children with type 2 diabetes and the impact of fasting during COVID-19. What advice is available for this group? And then he clarified that children are between 12 to 24 years of age, so his children and adolescents, and they are including the types of diet eaten by Muslims in the United Kingdom. So what general advice do you give him to consider during these on these studies? Can I start with anybody wants to give any advices?
Ahmed, can you ask the whoever asked the question, because we need to what he wants from us. So the study is already running there in adolescents and children, and were they looking at the relationship of fasting on the weight? Because obviously this is young obese type 2 patients who they're trying to fast. Obviously no Muslim, it's not Ramadan, so fast on the impact of the weight is it. And then there was a COVID-19, I've seen it as well. Factor. So I was not clear about what exactly is it. Is the study already running? What question we want? What advice to? Because if it is already ongoing, randomized control, whatever trial is, then I'm not sure what specifically he wants.
I think it might be a good idea, Muhammad, again, if I may, just to add. We'll be happy actually, because this might be a bit more of the theme of the of our talk, and because of sake of time we're running late. We are very happy to give you help, guidance and input if you could just communicate with us directly by email as well as WhatsApp. I'm happy to provide my phone number, and I'm happy to put you in touch with Ibrahim and Muhammad Bashir. So we are very happy. Thank you very much for just flagging this up. We are happy to contribute. No worry.
Yes, yes. Thank you, Dr. Tariq. There was a question about, somebody asked about telemedicine in Sudan. We have في مركز SOBA Research SETEC Research Center. There is a form of telemedicine setup, but what we usually do, and it's much easier nowadays, is through WhatsApp. for what has recently been mentioned by Dr. Tariq, that we are all happy to communicate with all the participants if they have any.
Sorry, the line got broken again with Dr. Shalaf.
Just to add to Dr. Abu Bakr, my number is there in the Sudis, Muhammad, Bashir, and Ibrahim Ma'mon, both of them.
So I think this.
If you flick through, you will find our number. You can send us messages. No worry.
I'm sorry, Salaf, we lost you after you mentioned about a center in Soba, and then we lost you.
Yes.
So you're back again.
I'm very sorry.
Please.
I'm very sorry.
No.
The connection. Yeah, because there was a question about, is there any telemedicine in Sudan? Some of the participants, somebody asked. We have we have this facility in Soba teaching center, but because of certain difficulties, it's easier for us to take calls through WhatsApp or email. We can discuss with the patient, with the participant, their different patients or the different scenarios if they have any questions. Just as Tariq mentioned, and it can be an open,
Thank you very much. The WhatsApp is the one method of communication. Yeah, and I remember recently I managed a case via a WhatsApp, severe diabetes with resistance, treated in Sudan for more than 2 years, and via the WhatsApp, I checked the photos and I prescribed the medicine, and I treated the case via the WhatsApp within approximately 10 weeks. So the WhatsApps can deliver messages for doctors and for patients as well.
That's great. However, I will caution here that you have to respect the rule of the country you're working in, because it's not allowed in every country to do that. Might in some places that cannot be could be frowned upon. So there is some question that came twice here. It's talking about what's the relation between diabetes and increasing weight, and it was posted twice, and I was buffeted a little bit about how to answer this or how to pass this question. So I'm not sure if the question is, why diabetes happens due to an increasing weight or diabetes causes an increasing weight. However, Ibrahim, you have done work on insulin resistance, and you have done work on genetics of insulin resistance. Do you want to answer this question, please?
As you said, the question is not clear, but obviously the obesity can lead to diabetes. Again, the diabetic patients, because of the poor diet, can have increased weight. Also, the medication some patients are taking, for example, insulin therapy, or even the glitazones can lead to increased weight. Again, if the patients with diabetes have got increased or repeated hypoglycemia, then they tend to overcorrect, and that can lead to weight gain. So the relationship between the obesity and type 2 diabetes, as you mentioned, through the insulin resistance. Again, obese patients, if they've got any evidence of secondary diabetes, we need to exclude other causes like Cushing or any cause of obesity which can lead to. But the general principle is that we need to tackle obesity, which is the fuel for diabetes and increased cardiovascular disease. I just wanted to add to the telemedicine question. I think that's a very valid question. We learned quite a lot from the COVID pandemic, the utilization of telemedicine, and that could be used safely. I think might be a good way of doing a pilot in Sudan, running this, what we've been talking about, the pre-Ramadan counseling, because it might be difficult in accessing the medical care. But if we provide that through a way of telemedicine, either phone consultation or even a video call, looking at the reviewing their medication, giving them the advice, that might be a good start. And then we can continue to do that even during Ramadan. And as Tariq alluded to, can be following Ramadan doing the same. So I think might be the way forward now in healthcare overall, not only diabetes.
Yes, Dr. Ibrahim, thank you for just reminding me that we have flyers in Arabic for our patients in simple words and in colored form, just to educate them. And at one stage, just before the COVID, we were thinking of this, like it's like a TV program which can come through into the smartphone. It's a sort of a video, an educational video for diabetic patients. But then the COVID came and we had to stop that. Dr. Muhammad Bashir, I see there's a question for Dr. Ma'mon Gibel about case 1. Somebody was asking about the Lantus, the use of how to modify the dose of the Lantus during. You remember the first case?
Yes.
So the basal insulin is easy if it is one of the new long-acting. Nowadays, maybe in Sudan they're still using the MPH, but for the long-acting with the Lantus or Levemir, Detemir or Glargine, the rule of thumb is to change the time of the injection instead of bedtime, to give it with iftar, to look at the patient risk of hypoglycemia, how tight the control is, and then what we need to do is reduction up to 30% of their dose initially, and then apply the titration algorithm was shown in my last slide.
That's very good. Can I add one word of caution here? Because the basal insulins are being given before iftar, because all of the old generation one, Ibrahim, if you agree with me, with Glargine, E100 and Detemir, they will have a tail end towards the end of before the second dose. So that's coincide with the time with the increased risk of hypo. So that will work for us both ways. So before iftar, with the tail end of the insulin, the patients are actually will be at less levels of hypos, and that's the time where we ask them to check. However, with insulin and MPH, the second dose, the peak actually could happen 4 to 5 hours after the dose. So those patients at high risk early in the morning and the start of Ramadan, of iftar, and they are much lower risk and higher risk of hyperglycemia towards the end of iftar. So the type of insulin can judge when we need to monitor and when to expect hyper or hypoglycemia, especially with MPH and its instability. There was one last question before we wrap up, because we've gone over time. And the question comes over here from Taha El-Tayyib. He said, can we accept slightly higher glucose levels in Ramadan? That's to say less tight control. If yes, will this increase the long-term complications of diabetes?
Tariq?
So I think it is a very good question. However, whatever we can actually achieve is to try to minimize any significant hyperglycemia in the same way we avoid hypoglycemia. Because in general, we do know that cumulative hyperglycemia through metabolic memory will lead to complications. So the context of Ramadan should not be very much different from the rest of the other days. We have to strive towards good clinical management of our patients. And this means that we should strive to achieve good control. Maybe to achieve ideal control 100% might not be feasible in every patient. And of course, every patient is different. But I don't think we have to be a bit lax or slang in our management. Therefore, I think I will be very cautious to accept that patients should be allowed to go for hyperglycemia temporarily during Ramadan in order to exercise safety. So I hope this answers the question.
I can agree more with
Yes,
Tariq.
I totally agree. تفضل دكتور إبراهيم.
I think what patients with looking up to us as a healthcare professional or diabetologist, endocrinologist, is to give them the go ahead that, oh, it's only 1 month, can I just lax on this and that will not have an impact. I think the Tariq should say that we need to be very clear about the message we get with our patients. It's involving them in the decision making, but at the same time provide them with the risk associated with having hyperglycemia. And most of the time, it's not only Ramadan. Those patients tend to have a poor control even outside Ramadan. So I think this has to be put in consideration.
Dr.
Yes,
Salaf,
I
you want to
totally
comment?
agree. Yes, I totally agree that we need to keep our patient within control, not to try to put him into hyper or hypo. But this just reminds me that, again, as mentioned by our speakers, that we have to individualize patients because control is different in different patients, depending on the duration of diabetes, the comorbid state. So we need to identify the targets for control in each patient, bearing this in mind.
Muhammad, just one last question. Do you want to take this? It's usually I ask this question, but was not covered during the talk, is the exercise. What the best time of exercise, what exercise to do, what exercise to avoid. Can you just answer that one? I think we've covered most of the diabetes and Ramadan.
You're asking the question too?
You or anybody just to answer, just quick advice on the exercise, what time to avoid, or anybody can take that one.
Okay, can I comment on the last?
I think Muhammad might be the right person because during Ramadan exercise before. Go ahead, Muhammad.
So before I go to that, I would like just to answer Abu Tayyib Tahir about this question. There is a guy called Munir, and Munir is a guy we always refer to when we look at the relationship between HbA1c and glucose, fasting and 2 hours, the Munir graph. Munir is a French scientist, and he actually did work on patients with diabetes in Ramadan, and the Muslims over in France. And Munir raised a huge concern about the hyperglycemia that happens during Ramadan. And he did a model that showed that the hyperglycemia, accumulation of the hyperglycemia over a long time will actually increase the risk of complications of Muslims. And he looked at the different way of glucose. He's the first person to look at glucose excursion during Ramadan. So he did raise this issue and this concern, and he did actually try to quantify them. So it's a very valid question and something we need to keep it always in our mind and as part of our educations. Regarding exercise, well, generally speaking, it depends on your medication, generally speaking. However, the safest thing for exercise is to exercise after iftar and even after Tarawih. Really, exercise can cause your blood glucose to go at various directions. And it depends on what form of exercise the person takes. Some exercises will get the blood glucose to increase initially. Some exercise will get the blood glucose to increase for a long period of time and then dips later on. And some forms of exercise will put patients at hypoglycemia, and all depends on the medications and the form of exercise. So the safest thing is to exercise after iftar and to monitor the blood glucose an hour or so after you finish the exercise, because that's the time, if there's going to be any dipping, it's going to happen there. That's generally, especially if patients taking medications like particularly patient with sulfonylurea or patient on insulin. Less so with other forms of exercise. That's for diabetic persons on medications, generally speaking. However, it's again an area that needs to be looked at, because when we looked at it in an objective way, when we put a patient, we put them on a Fitbit to check their actual exercise. And we did put a glucose monitoring, which is the Freestyle Libre. What we found is a mixed bag of fish. Some patients will shoot their blood glucose up and will not come down for a long period of time after an activity. And some patients will be at high risk of hypoglycemia. And that was very difficult to quantify. However, was mostly linked to their glycemic control and to their medications, particularly sulfonylureas. So safest thing after iftar, but again, monitoring is really, really critical. So
sorry.
Go ahead, please.
I'd like to comment. I'd like to comment on a question that was about obesity and diabetes. It was noted that patients, diabetic patients who are fasting, they tend to increase weight during Ramadan. Again, because of the type of diet they eat, they tend to rely more on sugary foods, more carbs. That's why they tend to gain weight. And
sure.
Are we going to wrap up? Before we wrap up, I have a comment.
I think we're going to wrap up. Yes, please go ahead.
Okay. Before that, I'd just like to comment. Remember that patients, type 2 diabetics, who are not going to fast Ramadan, we also have to take care and advise them on the dietary advice, because they are not fasting. In fact, they tend to eat more because they eat in the morning, their regular food, they eat in the afternoon, their regular, the first one is breakfast, then dinner, and then they come and eat again with those who are fasting. They break the fast with those who are fasting, and they feast with them. So in fact, in Ramadan, they eat more. And then we have the hazards of hyperglycemia and uncontrolled blood sugar. So remember, we also need to advise this category of patients.
For sure, and this is a very, very nice observation that actually nobody has brought it up for discussion at all before, but it's very, very nice observation. I don't think anybody put patients who did not fast to any form of testing, but it's really a good observation. So we need to wrap up because we exceeded our time. I would like to thank everyone for the very nice talk and for the engaging discussion. And it was really, really informative. And I can tell you that Zoom takes only 100 and there is an overflow to Facebook. And it was a very, very good talk. Dr. Salaf, the final words with you.
Oh, thank you very much. Again, thank you very much, elegant speakers and elegant presentations, and very, very informative and very updated. And I can see we have a large number of participants. And as you mentioned, even in Facebook, diabetes and Ramadan has been a great issue. And ever since we started in 2013 till now, the nice thing or the good thing is that we are having more and more research from Arab countries, and I hope people keep on still doing more and more research on this. And thank you very much. وكل سنة وانتم طيبين ورمضان كريم علينا وعليكم. ما تنسوا الأبرة والحلو مر.
نستوري لنا من السودان.
أوالي. Thank you very much.
Have a good night.
سلاف في مسج لك عليك الله في الواتساب. Regarding a patient I need your help with, huh?
Okay, thank you. I'll check it.
Okay.
Thank you.
شكرا يا شباب. السلام عليكم.
شكرا يا أخوانا. Thank you very much.
Thank you very much.
Have a nice evening. Bye.
Everybody. السلام. السلام طيبين.
السلام. انتم طيبين.
بخير.